or welcome back. Sorry this video is going up a bit late. We were out of town last week and so I'm just now getting around to filming again. But this week we're going to be talking about nutrition. Nutrition is a very important topic because our patients' intakes are where they get their calories for their bodily functions. However, in the ICU setting, I feel that nutrition is often overlooked or even dismissed because we assume that our patients don't feel well and that they're going to start eating when they feel better. However, we are doing our patients a disservice by withholding or just choosing to not evaluate their caloric intake. In people, malnutrition has shown to not only prolong hospitalization stays, but increase complications and increase mortality. There have even been studies in veterinary medicine that have shown that patients that are intaking less than a third of their required caloric intake are associated with a worse outcome. It's important to note that patients with critical illness metabolize their body's stores differently than healthy patients that have undergone starvation. The healthy patient that has had food withheld will still utilize glycogen or fat stores as a preferential energy source, whereas our critically ill patients will actually preferentially catabolize. They will use their lean body mass, their protein, as an energy source. Many of the patients in the ICU are presenting with subacute illnesses that has already predisposed them to an increased circulating amount of catecholamines and cytokines, which thus predispose them to this catabolic state of metabolizing lean body mass or muscle. In our patients, this just prolongs their healing times and potentially prolongs their hospitalization stay and worsens their patient outcomes. So this video is going to be all about how to get our patients' calories and the different types of feeding that are available to us in the ICU. But first, let's talk about how much nutrients our patients need on a daily basis while they're hospitalized. To understand that, we need to go over RER, which stands for resting energy requirement. RER is the amount of calories that a patient needs to maintain their body temperature at rest in a thermoneutral environment. There are two different formulas for calculating RER that you'll see. The first one is body weight in kilograms times 30 plus 70. And the second is body weight in kilograms times 70 to the power of 0.75. These two numbers don't produce hugely different results, but the latter, the equation that uses to the power of 0.75, may be more accurate in our really small or really large patients. But if you're just thinking about a normal cat, a 5 kilogram cat, if you're using these two equations, the first one is going to give you a caloric need of 220, whereas the second one is going to give you a caloric need of 234. So keep in mind that RER is a resting energy requirement. Most of our patients in a healthy normal state are not at rest, so most patients require higher than RER to maintain their current body weight. In fact, a normal, active, healthy dog could have anywhere from 1.5 to 1.8 RER on a daily basis. Puppies and kittens that are growing require up to 3 times their RER daily, and very active or working dogs can have even upwards of 5 times their RER every day in calories. Hospitalized patients are different though, because hospitalized patients have a lower energy expenditure because they're just not moving around as much. Most of them are just in kennels, they're sick, they're not feeling well. It's a job for us as their nurses to even get them to walk and go outside. So for our hospitalized patients, we consider their caloric need standard RER. Keep in mind that even obese patients do still require their full RER while they are hospitalized, because a period of critical illness, a patient that's hospitalized in the ICU, that is not the time to try to start a diet regimen. So how do we know when we need to start helping supplement our patient's caloric intake? Well, it's our job as the nurses to pay attention to if our patients are voluntarily eating. In general, it's recommended to start supplementing our patient's caloric intake in 3 scenarios. 1, if they have been anorexic for 3 days. 2, if they have been hyporexic for a week or more. Hyporexic meaning they're intaking less than 75% of their RAR. And if they have unintentionally lost more than 10% of their body weight. You can see that these questions all require knowledge of the patient's history, which is why a really good history is really important when you intake a patient. So how do we get our patient's calories? The 2 general categories are enteral feeding, which is supplied through the gastrointestinal tract, and parenteral feeding, which is an intravenous nutrition. The type of feeding that we're going to be supplying our patient is dependent upon the reason the patient is hospitalized, what their needs are, what their primary disease process is, how long they're going to be staying, whether they need a tube or feeding assistance when they go home, what our nursing ability is. Really is a whole host of factors that play into how you feed your patient. Enteral feeding is always preferable if the patient is able to tolerate it because it helps maintain our gastrointestinal health and it has less complications than parenteral feeding options do. However, there are certain circumstances in which enteral feeding cannot be tolerated and cannot be supplied to our patient. A couple examples include irretractable vomiting, GI obstruction, and an inability for our patient to protect their airway, so a lack of a gag reflex. The preferential method of feeding for enteral feeding is always going to be oral voluntary intake by our patient. Because it's the most natural way of eating, it requires the least amount of nursing assistance, and it's the most comfortable for our patients. But as I previously mentioned, our really sick patients often don't want to eat. So for our patients that are not eating or not eating enough on a daily basis, we have to start looking at tube feeding them. There are a couple of different options for tube feedings. The easiest type of tube feeding is nasal tube feeding, and this can be either nasoesophageal or nasogastric tube feeding. So in these circumstances, you place a feeding tube through the patient's nostril and it terminates either in the distal aspect of the esophagus for an NE tube or in the stomach for an NG tube. Your clinician will determine which is the best way of feeding your patient, but I find in the ICU setting, usually NG tubes are placed for a couple of reasons, but primarily they allow for gastric emptying. So they allow you to empty your patient's stomach, which is really beneficial for patients that have decreased intestinal motility and have very full, uncomfortable stomachs. NG tubes also allow for gastric residual quantification, meaning we are able to empty our patient's stomach before each feeding to see if their stomach is empty from the previous feeding. Some drawbacks with these nasal tubes is that you can only do a tube that is small enough to fit, meaning these tubes are the smallest feeding tubes that we can supply our patients with. Extremely small in our very small patients like cats and small dogs. The size of the tube thus limits what type of food we can give our patients. We're limited to liquid diets only. In large dogs that have larger size tubes placed, we can use very finely blenderized diets, but this does make our tubes more likely to clog. And then we have to attempt to unclog our tubes, and if we cannot successfully unclog the tube, that tube becomes useless. These nasal tubes are also pretty uncomfortable for our patients. I think they're one of the more uncomfortable feeding tubes that we can give them because they just stimulate their nose a lot. They cause really, really aggressive sneezing attacks in our very awake patients. Bad enough that patients will sneeze out their tubes. They're irritating. Patients try to paw them out. Alert patients often need to have e-collars the entire time they have the tube in, which makes them even less likely to try to take up oral feeding again. And also our patients are at risk for vomiting these tubes up. It's really important from a nursing standpoint to know that if anything happens to this tube to cause it to become dislodged but not fully out of our patient, you cannot just replace the tube. You have to replace it and take radiographic confirmation that the tube is in the stomach. These tubes don't have a high amount of complications. The number one concern is that the tube is inappropriately placed into the lungs. For obvious reasons, we don't want to be feeding our patients into their lungs. So anytime these tubes are placed, you do have to have radiographic confirmation. It's really common to say, well, I got gastric residuals, so I'm in the stomach, but that's not always the case. You still need to have radiographic confirmation that this tube is appropriately placed, because you can kill a patient by feeding it into its lungs. So no matter how sure you are, for the patient's sake, you should always take a view, make sure that you see the tube terminate in the stomach. This can be misleading on a radiograph, because just because the tube appears to move past the diaphragm does not mean 100% that it is in the stomach. I've found that the best way to confirm that this tube is appropriately placed in the stomach is by taking a lateral x-ray that includes the larynx. Here you can see that the tube actually moves into the esophagus and not into the trachea. For that same reason is why it's really important, if this tube moves at all, to always take radiographic confirmation that the tube is still in the stomach if you have to replace it to any degree, even if it doesn't come all the way out. The second most common feeding tube used in the ICU is the esophagostomy tube, also called the E-tube. These tubes are placed under general anesthesia surgically through the lateral side of the neck and into the esophagus. These tubes are a lot more comfortable for our patients. They don't sound comfortable to us because they're like entering through their skin into their esophagus, but they're less stimulating to their face. They're not sneezing as much, and I find that they just tolerate it much, much better long term. Also, these tubes can be larger. Therefore, we have a more variety of selection of what type of diets we can give the patient. The downside of these tubes is that they do require general anesthesia to place. So for one, they're significantly more expensive for our owner than placing a nasal tube that doesn't require anesthesia and often doesn't even require any sedation. Also, our patients aren't always stable enough to undergo general anesthesia. So there's a couple limiting factors here. If you have a patient that's undergoing general anesthesia for another procedure and anticipate that the patient is going to require long-term feeding supplementation, then an E-tube is a really good option. For the reasons already listed, nasogastric or nasoesophageal tubes are not good for long-term feeding because they're uncomfortable, they're small, prone to clotting, you can only use specific diets, whereas these esophagostomy tubes are much more realistic for week, month-long feeding supplementation. There are other types of feeding tubes, G-tubes and J-tubes, which go externally straight into the stomach or straight into the jejunum, respectively. And these are placed for certain disease processes in which you do need to completely bypass the lower esophageal sphincter or completely bypass the pylorus. Because these are less common and only done in certain scenarios, I'm not going to be reviewing how to do them or why to do them in this video. So now I'd just like to briefly go over how to place a nasoesophageal or nasogastric feeding tube. You're going to select your appropriate tube size. You want a tube that's small enough to, one, be comfortable to the patient, but two, allow them to breathe out of their nares still. So usually a tube that's about 50% or less the diameter of their nostril is going to be the best fit. You will need a couple supplies. You'll need a suture to secure the tube in place. Some people like to use tape, so it's also nice to have some white tape nearby. Lube to help the tube pass easily through their nostril, and syringes of whatever size you like, but something that you can sample gastric content to help yourself confirm placement before you take rads. You will need to get somebody to help restrain your patient, because if they're not sedated, if they're awake, they aren't gonna like this. You will measure your tube first. Do not forget to measure. You will take the tube out and measure past the last rib, so approximately to where their stomach would be if you're placing an NG tube. For an ND tube, you will place somewhere around the 9th or 10th rib. And you're going to stretch that all the way to their nose, make a mark to make sure you know how deep you're placing. I like to use white tape as my marker identifier, also because it helps me to secure the tube in place. On that note, I also like to start my suture before I attempt to place the tube in awake patients, because they don't like this process. It's really uncomfortable for them. So having that suture already started and available for you makes securing it in place faster, makes you less likely to have the tube removed by the patient while you're trying to secure it. So you're going to lubricate the end of your tube, and you are going to aim medial and ventral in your patient's nostril. Sometimes it's even helpful if you kind of push up on the base of their nose. You're aiming for the ventral meatus, which is the area that the tube can follow to actually pass down into the oropharynx. So aiming medial and ventral, you'll try to pass your tube. Sometimes it also helps if you stand behind your patient and lift their head up. I think it just helps with the angle a little bit. You'll try to pass your tube into the oropharynx. If you don't get into quite the right spot, the tube will not advance. So if you're aiming to dorsal, the tube will stop and it will not continue. You should not force your way back through. You should pull your tube back and try to aim more ventral. Once you've passed into the back of the oropharynx, the tube should be passing pretty easily. It is a good policy to try to pass the tube to the depth of the thoracic inlet and then aspirate the end of the tube. If you are accidentally going into the trachea, you will get air. If you are in the esophagus, you should get negative pressure. So that could be a good way to tell if you're going the right direction before your tube is completely placed. If you're in the esophagus, you should be able to easily pass the tube to your previously measured marker. You should aspirate the tube at that point, and if you're in the stomach, you should either get gastric contents or negative pressure if the stomach is empty. If you're in the lungs, you may get air or negative pressure. So if you get negative pressure, don't immediately assume you are in the stomach. I'd like to take a special note here to say that there are studies that show that patients can get iatrogenic pneumothorax secondary to a nasal feeding tube accidentally being placed into their lungs, and that this usually occurs when you attempt to remove the tube. So if you have a tube that you suspect is in the patient's lungs, or you have a tube you weren't able to place to your measured marker, or just anything that is an indication that you may be in the patient's lungs, you should have an emergency thoracocentesis set up in case your patient does get an iatrogenic pneumothorax and require a tap. But if you are hopefully appropriately placed in the stomach, you can either take your x-rays or suture your tube in place and then take your x-rays. I usually like to suture my tube in place so that I don't lose it when I'm moving to x-ray or to the radiology area. Because the worst thing that happens is your tube is in and your patient removes it while you're trying to transport them. That's why if radiology is super available, sometimes it's really nice just to place your tube in radiology, because then you can snap your quick lateral rad, confirm placement, and suture your tube in place all very quickly. When suturing these tubes in place, I like to do a finger trap just behind the nostril and under the zygomatic arch. I used to use the alternative method of suturing where you go in between their eyes and then suture to the top of their head, but I had a patient once that was hospitalized for about 3 weeks, and the tube had migrated in that time and it was loose enough that it was in their line of sight, and they were a recumbent patient, so when they were sleeping on that side, the tube was actually placing pressure on their cornea and they got a corneal ulcer, a pretty bad one. So for that reason, I just don't like to use the in between the eyes method anymore. Like, patients can see it. I just think it's less comfortable. It requires more sutures to keep in place. I just like to suture under the zygomatic arch. So once we have our tube in place, we then get to come up with a feeding plan. Sometimes your clinician will do this, or if you work together for a long time and you know what kind of feeding plans they like, you can take it upon yourself to start to calculate a feeding plan out. My standard is calculating RER, and then in patients that have not been eating, working up to that over a couple of days. If you're placing the feeding tube for some reason that is not anorexia, you can start off with a higher caloric intake right away. For example, we had a patient that potentially had esophageal damage from something they ingested. So we placed a feeding tube just to bypass the esophagus. That patient was eating normally up until that point, so we did not have to start with a lower caloric intake on that patient because they were already eating normally. But in patients that are hyporexic or anorexic, we want to work up to their RER. I like to start them on a quarter RER daily, and then a half, and then 3/4, and then on the 4th day perform full RER, which can just be their maintenance if they're in the hospital. If they're going home, it's important to keep in mind that after the patient goes home and their activity increases, you may need to increase their RER up to 1.2 or 1.5 or whatever you calculate based on the amount of activity they're doing at home. You want to separate your feedings initially in the hospital into about 6 feedings a day, and then you can increase the time between feedings when they go home to suit what the owner is able to do. So 3 or 4 feedings a day that are divided up to equal the appropriate amount of calories they should be getting. What diet they're getting is going to be dependent upon what kind of restrictions they have, if they need a low fat or a high protein diet, and also what kind of tube you have in place. Small tubes can only use liquid diets, whereas these larger esophagostomy tubes can use blenderized diets the owners can make at home. Royal Canin actually makes commercially available liquid diets that are almost 1 kilocalorie per ml. So it's actually really nice because you can just give them their RER in mils daily. And these come as renal diets, gastrointestinal diets, and recovery liquid diets. So that is all about enteral feeding, but we have a second option available for our most critical patients, which is parenteral feeding or intravenous nutrition administration. Parenteral feeding isn't ideal because you cannot get all of your patients' requirements from parenteral feeding. You typically cannot meet their caloric requirements because of the volume required to administer to them. But it may be life-saving in the days that it takes your patient to hopefully be a candidate for enteral feeding. There are 3 basic requirements that have to be met in order for your patient to be a candidate for parenteral feeding. The first, and one of the most important ones, is a dedicated central catheter or a dedicated lumen of a multi-lumen central line. Parenteral diets are very hyperosmolar, so as we've discussed in past videos, hyperosmolar things need to be given into a central catheter so that they're going into a large vessel and decreasing the likelihood of really bad phlebitis to that vessel. They are also high in nutrients, that's why we're giving them, which makes them more susceptible to bacterial contamination. So parenteral diets need to be handled with complete asepsis or sterility, meaning once you've connected your diet to the lumen or to the independent catheter that it will be going into, it should not be disconnected until you're discontinuing it. The exception is if your patient is continuing the solution and you need to replace the bag. In these cases, you should completely discard the entire set, so the entire extension set, and start over with the fresh bag. So even if the patient goes on walks, that line does not get disconnected. I like to place antiseptic material over all of the connections in the IV tubing to help try to preserve the asepsis or the sterility of this process. I will take chlorhexidine soaked scrub gauze and I will wrap it around the IV connection lines and then use a non-absorbent pad and tape to tape over it to make sure that stays in place to help reduce the likelihood of bacterial contamination. Our second requirement is these patients require 24-hour nursing care, so we cannot do this if we're in a practice that does not have an overnight staff. And it also requires frequent evaluation of some chemistry values. So you need to be able to run in-house blood work. We should be monitoring their BUN, creatinine, protein levels, and electrolytes at minimum every 12 hours, if not more. Because these diets contain dextrose solutions, some patients may be at risk for iatrogenic hyperglycemia and may require insulin administration. When we're doing our blood work, if our patient is receiving a diet that has lipids, we should also be evaluating our patient's serum or plasma for lipidemia. And the third requirement is that we need to either be able to make a parenteral solution or have access to a commercially available partial parenteral solution. The most common commercially available parental solution is procalamine, and this is an amino acid solution that does not contain lipids. So it is a partial parenteral solution because it is not giving our patient 100% of their needs. The downside of procalamine is that it is a pretty weak solution. So there's about 250 kilocalories per 1 liter of procalamine. That's a pretty small amount of calories for a pretty large volume. So we're not going to be able to meet the caloric requirements for our large patients. We may not be able to meet them for our small patients either, if those patients are more prone to fluid overload. For that reason also, patients with heart disease or that are a potential for fluid overload are not a good candidate for parenteral nutrition. No matter the route chosen for feeding, it's very important to monitor our patients for refeeding syndrome. Refeeding syndrome is a potential complication of starting nutrition in patients that are in a catabolic state. Refeeding syndrome causes an intracellular shift of electrolytes out of the vascular space into the intracellular space, causing a whole body deficit of potassium, magnesium, and phosphorus. So it causes hypomagnesemia, hypokalemia, and hypophosphatemia. This is why it's so important to monitor electrolytes in our patients. All right, well, that's it for today on why feeding is important for our critical patients and different types of enteral and parenteral feeding. Make sure you stay tuned to the next couple of weeks. I'm going to be starting a transfusion series about all the different types of blood products and how to perform blood transfusions in patients. So if you've made it this far, as always, please like this video, subscribe to my channel, and we will see you next time. Don't step on that.